Hi everyone, my name is Mike Carlson and I am presenting a case from my clinical rotations at Mountain View Hospital in the emergency room. I'll be discussing a case about a 54-year-old female who presented to the ER with complaints of increasing abdominal pain and vomiting that started earlier in the day. The pain, she stated, was diffuse, rated at a 9 out of 10, associated with bloating and abdominal distension. She had persistent non-bilious vomiting and no history of fever or diarrhea. Upon evaluation, blood work, and a CT scan, we confirmed that she had a diagnosis of a small bowel obstruction. I'd say that the reason that this case was so meaningful or stood out to me was because of the complexity and severity of the patient's presentation. Small bowel obstructions can be life-threatening, and although she was clinically stable upon arrival, through timely intervention and a collaborative approach, were critical to stabilize this patient. This case just kind of reinforced the importance of utilizing structured differential diagnoses and using current best practices and through that, we were able to guide our treatment decisions, especially in the context of the abdominal pain and vomiting. So, ID, CC, and HPI, again, initials were AJ, 54-year-old female, who presented with the chief complaint of increasing abdominal pain and vomiting that began this morning. The pain, she stated, was described as diffuse, severe, 9 out of 10, and worsened with eating, which she stated that her last meal was in the morning and fluid was in the morning. Associated symptoms included bloating and abdominal distension. Vomiting followed the onset of pain which was non-bilious, and no associated hematemesis. She denied any recent travel, no dietary changes or stressors that were noted. The patient has a past medical history of hypertension, asthma, anxiety, and depression. Previous surgeries, a couple arthroscopies of the left shoulder, colonoscopy, appendectomy, and a hysterectomy. She denied any use of drugs or alcohol. Family history was minimal, with mother having hypertension, diabetes mellitus. Father coronary artery disease, hypertension, and dyslipidemia. So the review of systems, she just basically complained of increasing tiredness, no fever, no weight loss. Stated the diffuse abdominal pain, cramping, nausea, vomiting, no hematemesis. Denied any chest pain or shortness of breath, though reported getting winded after vomiting. Her vital signs were all stable, although she was a little bit tachycardic, just over the 100 mark at 101, and 9 out of 10 pain. Upon the physical examination, she had a mildly distended, tender to palpation, with some guarding noted in the upper quadrants. However, she did have tympanic residence in the right upper and left upper quadrants. She did have some decreased bowel sounds in the left lower quadrant. Otherwise, all systems were unremarkable. The diagnostics we used, CT, abdomen, pelvis, with contrast, and the findings were consistent with a small bowel obstruction with dilated afferent and efferent limbs, with no free air or fluid. Her blood work was also unremarkable. Differential diagnoses considered were small bowel obstruction, given the symptoms and findings in the confirmation with the CT exam. Although I did utilize two other diagnoses that I kind of thought were likely as well, but ruled out. So acute pancreatitis with a similar presentation, but her amylase was 19, her lipase was 9, which were both within normal limits. No jaundice, which kind of made the diagnosis unlikely. I also thought about gastroenteritis, but that typically presents with diarrhea, fever, recent exposure to contaminated foods, none of which were reported from this patient. And then the CT findings made this diagnosis less likely. The critical thinking process, the patient's presentations initially seemed like gastroenteritis, but the absence of diarrhea and fever combined with her abdominal pain or her abdominal exam findings and imaging led me down the road of SBO or small bowel obstruction. And that ended up being her final diagnosis. So the plan for this patient was CT, abdomen, pelvis with contrast, confirmed the diagnosis. Additional labs, CBC, CMP, amylase, lipase, CRP, and UA, all of which were negative and no signs of infection or pancreatitis, so normal results. Treatment plan, we were going to, after collaborating with general surgery and the hospitalists, admit this patient on bowel rest. We placed an NG tube for decompression, which coincides with the current clinical guidelines for this diagnosis. IV hydration, electrolytes to maintain fluid balance, pain management with narcotics, which we used fentanyl and Zofran for nausea. And the IV antibiotics at this time were considered, which would have been ciprofloxacin and Zosyn. However, at this point, according to the current clinical guidelines, we were holding off unless she wasn't able to self-resolve. So the surgical consultation, given the severity of symptoms, Gen Surg was consulted, and then if the obstruction didn't resolve conservatively, surgical interventions would be considered. Education and family discussion, education about small bowel obstruction, just to kind of what they can be caused by, which were the adhesions from past surgeries like appendectomy or hysterectomy, and the goal is to essentially relieve the obstruction and prevent complications like bowel ischemia. If the obstruction persisted or complications were to arise, obviously surgery would be necessary at that point. So for follow-up, if the patient improves with the NG decompression and IV hydration, the tube would be removed after 48 hours and a study with the gastrogafferin. And so as far as evidence-based practice, why I chose this approach using conservative management, according to Mong et al. And Jackson and Cruz, which are the current clinical guidelines for treatment of small bowel obstruction, was the NG tube and IV fluids and bowel rest. So the clinical presentation and management protocols kind of really fit that line for treatment. The recommended approach for small bowel obstruction with imaging as a guide from Mong and Jackson and Cruz, consensus on conservative management as the first line for uncomplicated small bowel obstruction, which that's how she was presenting. Obviously, the alternatives were considered if there were signs of bowel ischemia, rising white blood cell counts, if any evidence of perforation, or if conservative measures had failed. So the holistic care or holistic approach in caring science. So the collaboration with the care team was unique, and I think that was probably why I kind of, thought of this as a kind of a measurable, because I actually got to speak with the surgeon on call, the general surgeon, and kind of just discuss the case, and given the diagnostics and findings, came up with a plan that we would take surgical or conservative measures. Cultural considerations ensured that the patient's concerns and understanding of the diagnosis were addressed, respecting her family dynamics and communication preferences as she was there with her husband. So, spending time in the room, kind of going over all that for ease of mind. As far as Jean Watson's caring processes, caring for the patient's body, mind, and spirit. The patient's psychological comfort was important given her history of anxiety, and her emotional needs were considered through education and clear communication, which I spent an ample amount of time with them, gaining trust. And which leads me to the next Jean Watson caring process, which is building trust. I provided regular updates to both the patient and family about the plan and prognosis, and I believe that I showed empathy toward her distress and kind of her uncertainty about the situation. Lastly was the holistic care through a patient-centered approach. We balanced her medical needs with emotional support. We collaborated with her family and made sure to involve them in all the decisions as her care progressed. All right, thank you.